So, hi, welcome everyone. Thank you so much for joining us again for the Empowered Patient Podcast. Today, I have the distinct pleasure of meeting Dr. Amy Killen. Dr. Killen is an amazing menopause specialist, and she's going to tell us all about the things that she's doing to move and shake the menopause world right now. Welcome, Amy.
Thanks so much for having me. It's great to see you again.
Yeah, absolutely. My pleasure. So, tell me, what are your latest and greatest things that you've been working on? What are the things that you most want our listeners to hear about?
I have several different things I'm doing. I have a clinic that's where we're expanding and we're franchising. It's called Humanot Health. We're in Austin, Texas, and also Palm Beach Garden, Florida. But we're working
Oh,
on going kind of national. I'm the one of the co-founders and chief medical officer. So that's been a lot of fun, a lot of work.
wow.
And then I'm also working on a book. I'm writing a women's longevity book that I just sold to the publisher. So I'm super excited about that, which is
Oh, that's great.
it'll be a little while until that comes out, but that's a lot of fun as well. And then social media, I'm still doing a lot of education and love that as well.
You are. I love watching your social media. In fact, I'm going to quickly just put this up real quick so that people can see it. So people can connect with you on social media as well, because she is one of the leaders, if you ask me, in the menopause space. And so tell me about, where do you get your content from? Where do you usually make your decisions about what to film?
I just take questions that I've gotten from, either my own patients or I do a lot of, I oversee mid-level providers, NPs,
Hmm.
PAs in my clinics. And then also just things I'm curious about. Like sometimes I'll just be really curious about something and I'll just start, I'll take a multi-week or multi-month kind of deep dive into it because I have my own questions and I want them answered. So
Sure. And one of them you just posted this week, I saw on your Substack, was about the Dutch test, which we'll circle back to in a minute.
yes.
But I also wanted to ask you a little bit about your pathway, because, a lot of one of the things that we talk about here on this podcast is about how we are moving and shaking and developing medicine, and how things are changing so quickly in the whole world of how we give medicine to patients, how we interact with patients, and how they are learning more and more from social media and from virtual platforms, what have you. So I'd love for you to just share with us a little bit about how you got to where you are.
So I was an emergency physician. I was an ER doctor for the first part of my career. I'm board certified in emergency medicine. I worked in a busy ER in Austin, Texas, and it was great. I did ER for about 10 years. Towards the end of that, I had three kids within 2 years. So I had all these little babies at home, and I was working a
Wait,
4
let me do that math.
I know.
Twins?
Well, I had twins plus one more. Like, how is that work?
Sorry.
So I had all these little kids at home and I was working a shift in the ER that started at 4 in the morning. So I was, sleeping 3 or 4 hours a night and getting up early and going to work. And just as you might imagine, because I know you've been throughout with all the stress of medicine, not sleeping well, not eating well, stressed
Mhm.
all the time, not exercising very well, and just
Three cranky kids.
kind of falling apart a little bit.
Yeah.
And I just had this revelation one day. I was in the ER. I was looking out at the waiting room at all the people who are waiting to be seen,
Hmm.
out there. And I just realized that if I didn't get my act together and make some pretty serious changes, then I was going to be one of those patients in the ER waiting to be seen for probably a chronic medical problem that may have been able to be prevented. And so I needed to start making some changes. So that was back in 2013, and I've
Wow.
been in the hormone space, the menopause space, women's health space ever since then.
Love it. I love it. And one of the things that you just pointed out is the fact that you decided to take care of yourself, because you realize that unless you take care of yourself, you're not going to be able to help anyone else. And that actually circles to almost exactly to my mantra, which is put yourself first.
Yeah.
And I deal with that a lot with my cancer patients, who are often not focusing on themselves, but instead on everybody else. And that tends to be, a very common theme for women, especially in the United States. But
Yes.
so you have a clinic that's in Austin and in Florida, and you see patients virtually, or you see them in person, or both?
So that those clinic, I don't see patients at those clinics. I just
Okay.
oversee. I create the clinical protocols, and then I
Uh-huh.
oversee the mid-level providers. We go over,
Okay.
patients. I kind of see them through the providers that way. But I also
Gotcha.
have a regenerative medicine clinic here in Utah, which is stem cell medicine clinic that
Oh, wow.
with my partner here. We do stem cell procedures for. I do primarily aesthetics, so like, face, scalp for hair restoration, and I do sexual optimization procedures also. And then my partner does musculoskeletal, neck, back, joints, things like that. So I see patients there. And then I have another clinic here in Utah as well called Biorestoration, where I am an owner and also set up the protocols. I don't see patients, but I'm involved in kind of making sure that everything is staying on track.
And what do they do in that clinic?
Same kind of thing. A lot of hormones. Like, we're Utah's
Uh-huh.
largest bioidentical hormone
Oh,
clinic,
wow.
and we've been doing this. It's funny because there are a lot of fantastic, traditional kind of allopathic doctors who have gotten into the hormone space in the
Sure.
last few years, and you're hearing a lot about this stuff. But
Yeah.
I was lucky enough to start to kind of discover this back, 13 years ago,
You're one
and
of the OGs.
I am. I'm one of the. I mean, and there are certainly people who are even more OG than me, but I've been lucky enough to be in this space and kind of gotten turned on to how important these hormones can be a long time ago. So we built up the clinic here to be a pretty amazing hormone provider. We also do other integrative medicine and lifestyle medicine, and we do a lot
Mhm.
of things as well.
Mhm. Well, that's actually interesting. So now we can segue over to your most recent Substack, because when you tell me like integrative medicine, functional medicine, some of those types of things, I want to hear more about the stem cells, of course, and where exactly you could put them in my face, because I'll certainly fly to Utah for that. One of my classmates from Princeton, when I was an undergraduate, he lived across the hallway from me when I was a freshman. A genius, and his name is Dr. Sam Lamb, and he went into plastic surgery, and he is doing all kinds of phenomenal things down in Dallas. And so after I fly down there, I'll then jump over to Utah so that he can, I'm gonna look better by the time I'm 60 than when I did when I was 30 for
That
sure.
sounds
So
great. Yeah, I mean,
yeah.
stem cells they can be added to anything. So that sounds
Perfect.
fantastic.
We'll have to talk offline. Anyway, but just tell me a little bit about this whole Dutch test thing, because, and the reason I find it super interesting is as now I've gotten more um, interested in the hormone space and in the functional medicine space, I find that there's really very, a black and a white. People either like it or they don't, and
Yeah.
I find it very interesting. And I'm not really sure where I fall on that. And so I found your publication very, very interesting. But I would love for you to tell everybody about what the Dutch test is and your thoughts on it.
So the Dutch test is a urine estrogen. Well, it doesn't just measure estrogen, but
Right,
my article was about estrogen. It's a urine
right,
test. It's a dried
right,
urine test. You do it at home, and it essentially looks at all different hormones. It looks at testosterone and
right,
DHT and estrogen, and it looks at the hormone itself, but it also looks at the metabolites. How is your body breaking down that hormone?
right,
And it's giving you a lot of information. And so the critique about the Dutch test, a lot of physicians don't like it, and the critique is that it hasn't really been validated.
right,
We can't agree on whether one pathway is good versus bad. We can't agree on whether we can actually change, the pathways in some way with lifestyle or supplements. Like, there's just a lot of
right.
disagreement. And
Sure.
so the medical guidelines by the big organizations are basically that we're not going to support that test. However, you also have functional medicine doctors, many of whom are brilliant friends of mine who've been doing this a long time, who have used these tests for a long time because they do believe that the biochemistry, understanding specific biochemistry about how we metabolize estrogen, very well could help us determine why some people are more prone to get breast cancer or endometrial cancer or any of these, estrogen sensitive cancers.
Endometriosis.
Yeah, exactly. Like,
Yeah.
how
Right.
you metabolize estrogen in the
Right.
liver and in the gut
Yep.
certainly plays a role in, your symptoms and potentially disease development. But so I was very interested because I kind of
Yeah.
sit at the middle, but in between these two camps, and I didn't
Sure.
ever know what to tell people. I wanted to make sure that so I essentially did a multi-month kind of deep dive where I went back to every study I could find
That was an
and
impressive list.
put it all on a list, and then tried to look at it from different angles. Like, are there populations that we understand more about, less about? Like, what are we
Mhm.
missing? Things like that.
Right. Right. That was actually brilliant. I would love to, maybe in the show notes, I'll put a link to your Substack, because I thought that was very, very interesting. And you
Thank
did a
you.
very thorough job. In fact, I was
Thank
extremely impressed. Would
Oh,
any AI involved in that, or you did that all manually?
so I use AI to help me find studies. I
Hmm.
like to, it's a great tool. I use Perplexity, for instance. I think is really
Okay.
helpful. Sometimes
Yeah.
it makes up things sometimes, but
Does it?
then I go to the study,
Right,
obviously,
of
through
course,
the
of
study
course.
and
Yeah,
put
I
it
do the
into.
same thing.
Yeah,
I
yeah,
think it's the best search engine that there is. I've
it
been using GenSpark.
Oh, I don't know that one. Yeah.
It's like Perplexity. So
Yeah, I think that AI is great. I think it's fantastic. The problem is, like, that kind of question about the Dutch test, like, you can't
right,
I tried just beginning, like, by asking, "Tell me about the Dutch test." Like,
right,
"Is it
right,
useful? Is it not useful?" But the thing is, it's pulling from it all information all over the web, and it's pulling from whatever information is kind of most consistently out there. And
right,
one thing I found that you'll find interesting is, if you were to like to look up, there's just these different pathways, and
right,
some essentially one is considered by people to be like the good safe pathway, and
right.
the other two are considered to be maybe less safe. And so if you go online, everywhere you look, there's all these diagrams of these pathways. Every
Mhm.
person has labeled these pathways as
Good and
being, this
bad.
one is good and these
Right,
two are bad.
right,
Everyone, like major
right,
publications. And
right,
so, but I went back to try to figure out, like, why do people think that? And the data on that is very inconsistent. Like, we do not have solid evidence that there's one pathway that is good and the other two that are bad. It is very mixed bag, very muddy data. And so I think that it's you got to remember, like, a lot of times, like, AI is pulling from, potentially problematic data sets. So you have to
right.
kind of go back to the source. So
Yeah.
it's interesting.
So one thing that I've actually become very interested in recently, I don't know if you've looked at any of this at all, is functional genomics.
Mhm. Yeah.
So basically, take the DNA from a patient, you run their DNA. I did it on myself, I did it on my daughter. And you can look at what they call polymorphisms, which I know that you know what that is, but for our listeners, a polymorphism is sort of a variant of the DNA at a particular gene. So I can have a gene that has, you know, one subtype, and Amy could have a gene that has, one of those subtypes and maybe another one. And so in a simplistic view, there could be, a good, a medium, and a bad version of that particular gene. And so polymorphisms are just changes at those genes that are still normal. They're not abnormal, but they may not function the same. And one of the reasons I think that's so interesting is that one of the pathways that I have been involved with in the past, particularly because of tamoxifen and because of the role of depression and what have you, is the MTHFR gene.
Mhm.
So, MTHFR happens to be one of those genes that is probably a lot more prevalent in our society than we know about because people don't necessarily test for it. I happen to have the mutation, and I found that out sort of in a roundabout way. But at any rate, why it's important to know that is that there's some studies that show that, for example, if you're on tamoxifen and you have an MTHFR mutation, you might not be metabolizing it properly and therefore may not be getting the full benefit of the drug. But there's other aspects of it. For example, I don't, because I have this gene, I can't use vitamin B12 in its normal form because I don't have the gene that can make it active. So you
Yeah.
need that gene to be able to make B12 methylated and then therefore active. So why is this important and what does this have to do with the Dutch test? When I look at that test and I look at those different metabolites of estrogen, in other words, how estrogen is broken down in the body to get rid of it, I think it's really important at some point to also look at the genomics component of it
Yeah.
because we know that there are certain genes that help break down that estrogen into those different pathways. And if you are deficient in one or another of those, proteins that help it break down, that could give a lot more credence or information to the patients. And I just think that that's going to be something in the future that we're really going to hopefully be utilizing more to help personalize medicine.
Yeah, absolutely, and a lot of the functional medicine doctors, the kind of longevity doctors, this is
Yeah.
that they have been doing these kinds of tests for a
Yeah.
long time, and
Yeah.
luckily now we have with AI, we have the ability to insert like large data, data sets and
Yep.
information. So you can take your genetic information, you can take epigenetic information, which is kind of like how lifestyle and other things affect how your genes are interpreted. You can
Right.
take that data, you can
Right.
pile on top of it something like the Dutch test, which I don't think everyone needs the Dutch test. I do think
Right.
that especially as we get better at interpreting data, like large data sets, we will be able to use those kinds of tests better. I think right now it's still a little bit like, not sure what to tell you about your Dutch test, but I
Right.
do think that there's a place for those kinds of tests, and we'll really be able to give you so much better personalized information.
Right. No, it's amazing. It really is amazing. And it's amazing what you can get at home by just spitting into a tube or peeing in a tube and sending it out in a
Yeah,
box to
yeah.
another state. And then they get all this information. But you're right. I mean, a lot of times when we get all this information, you don't necessarily know what to do with it.
Yeah.
And so, that's definitely one of the pitfalls at this point until we work out more of those details. But so tell me more about your longevity clinics and what are you doing there?
So at Humanot, which is like astronaut, but with humans, so Humanot Health
Oh,
is
that's cool.
it, yeah, it's kind of fun.
Yeah, that's cool.
We basically have brought together I've been doing a lot of different things for a lot of different years, and essentially
Mhm.
we brought a lot of those things together under one roof.
Right. Right.
And so we do bioidentical hormones for men and women. We do midlife hormones, et cetera. We do genomics testing and all different advanced kind of diagnostics like that, where we're checking all these different types of diagnostics to try to really get a good picture of you. We
Mhm.
also do some in-clinic testing, like we do a VO2 max testing, which is where you run on the treadmill and it's looking at your cardiorespiratory fitness because we know it's highly correlated with longevity. If you have a high VO2 max, your longevity is much better than a low VO2 max.
Right.
We look at your artery in your neck and see if you have plaque in your artery. We do DEXA scan to look and see how your bone mass is. So some of those kinds of tests in clinic.
Mhm.
And then we have providers that are trained specifically on the protocols that either that I developed with help from my team to really like very specifically give you that personalized plan that involves maybe medications, supplements, lifestyle. Maybe we also do stem cell medicine, so we do regenerative medicine there also. So we have kind of added into one place all of the things that we think can move the needle to keep you healthy for as long as possible.
Wow, it's amazing. So tell me a little bit. I don't know much about this regenerative medicine and the stem cells. So other than injecting them into my forehead here to make my skin look younger, what else do you do with them? What do you do? Where else are you injecting them?
We can, I mean, the most common areas that we're using regenerative medicine and the most studied area is for musculoskeletal pain. So, your knee hurts, you've got a rotator cuff injury, you've got a
Mhm.
tendonitis in your foot, many years worth of data on stem cells for those kinds of things. Certainly different, some data is better than others. They're very
Mhm.
safe.
Mhm.
And basically the options for stem cell therapy is you can either take your own stem cells, like I could get
Mhm.
your stem cells from usually we're doing it from fat at this point, like just do a little mini liposuction in your hip,
Really?
on one of the sides. Or we can do bone marrow aspiration as well, but
Mhm.
essentially get your own stem cells. Or we also can use stem cells or like growth factors and such from another person. Like
Mhm.
like usually it's placental tissue that's been donated, like after a healthy C-section, the tissue
Right.
gets donated to a lab.
Sure.
And so we can use that placental tissue as well. And we can put them in the joints, we can put them in, I do, aesthetics, so I put them in the face. We use them for hair restoration or to improve hair health, which is like scalp injections. And then I also do sexual injections, which I've been doing for 9 years or so. They work phenomenally well in men, a little less well in women, although certainly can be beneficial. But essentially, injecting directly into the penis and into the corpora cavernosa in men, and injecting in women into the clitoris and then anterior vaginal wall. But essentially, the goal of all of
Are
this.
you under
I know
general anesthesia
you're like
for that, I hope?
go
Jesus.
back. We numb you first. We numb you first.
I hope so.
Do not worry.
Oh
Uh,
my god.
the goal is to all stem cells are just they work as signaling molecules. So essentially,
Sure.
when we put a stem cell in our stem cells into the body, we're essentially trying to get your own cells to
Right.
become more active again. So we're just
Mhm.
signaling to your cells, hey, like stop acting like 55-year-old cells and start acting like 35-year-old cells. Like,
Right.
we
Sure.
try it's increasing blood flow, decreasing inflammation, increasing healthy cellular activity. So it doesn't fix everything. It's not a
Mhm.
panacea, but I do think that the regenerative medicine it's a great tool to add
Mhm.
to the toolbox that we have.
So say you had a patient that had like chronic arthritis in their knees and they were always in pain and they didn't want to get a knee replacement or they weren't a good medical candidate for a knee replacement or something. Is that something that you would be able to do an injection for?
Yeah, absolutely. Yeah, arthritis, osteoarthritis is a great indication for these things. And certainly, if you have something that needs to be fixed with surgery, it's likely that stem cells aren't going to fix it. But we have had people that have been able to put off getting a hip replacement or a knee replacement for a number of years because we
Mhm.
were able
Mhm.
to reduce inflammation and improve
Right.
decrease like some of the signaling in the nerves around the tissue that there's pain, and help to repair that tissue enough to get you maybe a few more years out of your knee.
Sure. Wow. That's amazing. That's really cool stuff.
It
I
is
get,
cool.
that is great stuff, really. I mean, and how you got there from emergency medicine is beyond me, but that's amazing, though.
Yeah.
Um, So what other things do you what things do you like to do in your free time? You're in amazing shape if anybody hasn't seen her on
Oh.
Instagram. I mean, every time she posts a picture of herself at the water, I'm like, "How does she do that?"
Well, thank you. I live in Utah, so I live in Salt Lake City. So I live right up against to a mountain essentially. So one of my
Mhm.
favorite things is just to hike, to go up in the mountains and go hiking. And we have a mountain lion that likes to live in our yard occasionally, which is not a good thing because they're super scary. But that's my favorite thing. And then I like to lift weights, certainly 3 or 4 days a week because I'm pretty skinny. So I got to try to get my muscles up as I get older here.
Got it. Well, that's all really good stuff. And how about what other lifestyle things do you like to do? Do you travel a lot? Do you like to
I do, I have been I am traveling more than before. I've been doing a lot of speaking. Like in the next month I have like 10 different speaking engagements
Wow.
around the world. And so it's going to be crazy town. And the problem is when I travel, I don't tend to be as good about exercising or
Mhm.
as well as sticking to a healthier diet. So I usually come back pretty exhausted and like not happy with myself. So I got to do a better job at that.
So what are the two biggest ones that you're speaking at so our listeners can hear about them?
I'm speaking at Eudaimonia, which is in November in Florida. That's a big one. I'm speaking
Uh-huh.
at the HLTH, which is a huge conference in Vegas. I just got the invitation yesterday on
Ooh,
that
I may
one.
be going to that.
Oh, good, good. And then I actually have a couple. I have one in Saudi Arabia and one in Switzerland, which are
Wow.
going to be coming up as well.
Do
So
you
it's
need an assistant, maybe an
yes,
oncologist to
I do.
help
I
explain
do.
anything that people don't understand
I
about
definitely
cancer?
always need an oncologist in my pocket.
I'll take it. Oh, that's wonderful. That's really great. I haven't heard you speak live, but I'm looking forward to it. I think I'm going to go to that HLTH conference actually.
Good, good. We'll have to hang out. It'd be fun to talk to you there.
So let me ask you, because I always have to ask people after I've spoken to them virtually and never seen them in person. How tall are you?
I'm 5'9" and a half. I'm pretty
Wow.
tall.
So, see, good thing I knew that because otherwise I'd be surprised when I saw you because we all look like we're this tall.
I
I'm only
know.
5'4".
Yeah.
I know I stand tall, but yeah. So that's always funny when I meet people for the first time because you never know how tall they actually are.
Yep.
Yeah. So that's really interesting. So what other things would you like to talk about today?
You want to talk about maybe vaginal estrogen? I think maybe talked about how
Yeah.
who's a good candidate and why it's important.
I think that'd be great. I mean, I think a lot of my listeners would really like to hear about all of that. And I think that the tide is definitely turning on this, and that more and more practitioners, especially in the oncology space, are willing and able to prescribe it. But yeah, why don't you tell us all about your thoughts on it?
So, my thought on vaginal estrogen, which is that all women over the age of 50 or so should be have a discussion with their doctors
Sure.
about vaginal estrogen. Certainly, not everyone's going to choose to do it, but this is a very, very safe hormone that we can give you that just works in the pelvic floor. So we're giving you a very low dose, which means it's not really dramatically affecting the hormone level in
Right.
the rest of your body, which is why it's very, very safe. And what's great about it is, it's great for sexual function. It's great, to improve or keep everything lubricated and sensitive and, it's not atrophying and all that. But also it can really dramatically reduce recurring bladder infections,
Hmm.
and it can dramatically reduce like bladder leakages, like stress incontinence, your urge incontinence
Yep.
as you get older, which is a big problem. And just improves it. Just women are very much happier, sort of with their pelvic floor health when they're able to take something like this. I find so it's a great tool, and I think it's just underutilized, unfortunately, because there's still estrogen still has kind of a bad rap in some doctors' minds.
Yeah, no, I agree with you. But even when I was at Memorial Sloan Kettering, we did studies ourselves. We did one that I participated in on with Vagifem, the tablets that you insert,
Uh-huh.
and really didn't show any increased risk of breast cancer recurrence in the patients that were utilizing them. So
Yeah.
we were even using those in our ER positive breast cancer patients as well. What are your favorite formulations if a patient were to go and ask for it? What do you think are the best ones?
I most commonly just use the estradiol cream, which is a
Hmm.
pharmaceutical product. It's a 0.01% estradiol vaginal cream.
Right,
And you can, I tell patients, there is an applicator, but you can also just use your finger. You don't have to go in very deep. You really just need to go in like an inch,
right.
because we're just trying to get kind of around the urethra and around, like the just inside, and then also kind of put it on the outside as well. A lot of women don't realize that if without estrogen over time, you actually get atrophying of of all the tissue down there, like your
Right.
clitoris atrophies, your lips atrophy, of course, the vaginal tissue atrophies.
Right.
So yes, you just do it 3 times a week. It's really easy before bed. And there are other forms, like there's estring, which is a
Right.
ring
A
that you put
ring.
in that
Yep.
stays for 3 months. And that's an easy
Mhm.
way to do it too. But yeah, the tablets that are also easy. There's several different options, and
Sure.
there's great pharmaceutical products out there. All you got to do is just get a prescription, unfortunately, for it.
So, do you want to hear something funny? I was on a girls' trip about a year ago with a bunch of friends. Shout out to Colleen, and we were talking about how beautiful her skin was, and she said, "Oh, well, that's because I use my vaginal estrogen cream on my face." We look.
Yep.
Everybody at the table was like, "You what?"
Yeah.
I hadn't heard of that before, and so I don't know if any women have heard of that, but I know that you can get estriol creams and
Mhm.
other creams out there to use, but apparently you can use this vaginal estrogen cream on your face for wrinkles as well. Have you heard
Yeah.
patients doing that?
Yeah, absolutely. There are actually a number of studies that are, they're all small studies. Like, we probably
Right,
should do more research, but there are studies on using the same dose, that
right,
0.01% estradiol, or you can also use estriol at a little higher, like a 0.3%. But
right.
again, it stays locally when you have that low of a dose. So you can put a
Mhm.
little bit on your face, put a little bit inside your vagina, and then you're all set.
Little dab everywhere, a little dab wherever you need it. I don't know the data on the safety of that for women with breast cancer, putting it on your face. So
Yeah,
I just want to put that out there that it was something like I said, I heard on a girls' trip, and I thought,
yeah,
huh, well, that's interesting. Now that I've turned 56, I feel like I've passed that 55. Like, oh, I'm heading towards the 60. I got to start
yeah, yeah.
you know, collecting all of these thoughts and ideas. So, oh, that's amazing. That's
And
amazing.
as you know, like, it's interesting because estrogen, if you put wherever you put it on your body, it will get absorbed. So
Right,
one of the confusing points, people are like, well, I don't understand how it's staying. How is it staying just on my face, or how is it staying just in my pelvic
right,
floor? And the answer is that it's just all about the concentration, the dose that we're giving. So we're
right,
giving, a dose that's about a tenth of the dose, say, of if you were to use a estrogen cream on your arm that was supposed to treat your whole body, that's a lot
sure,
higher dose. And so it's all about the dosing. So certainly if you take that tube of vaginal estrogen and you put a little on your face and a little on your neck and a little on your arms and a little on your, like, essentially you will get to the point
you
where
can build
you're
up to a real
yeah, I
dose,
mean, you're
right,
essentially giving yourself a systemic dose, if
right,
you use it a lot. So certainly for breast cancer survivors, if you're trying to avoid estrogen, you
right,
can overdose yourself
sure,
on a low dose vaginal cream if you don't use it in a low dose.
true, true. So, in terms of other menopausal type replacement therapy, what do you usually prescribe for the average woman who walks in and I've got all the symptoms. I've got the brain fog, I have the fatigue, I have the lack of motivation, I've got vaginal dryness, I've got, risk of heart failure or heart disease. What do you usually?
Yeah.
And I
Well,
have a uterus.
and you have a uterus.
And I have a
Well, I
uterus.
I I am a big fan of menopause hormone therapy, bioidentical hormones.
Sure.
I most commonly use a transdermal estrogen of some sort, a patch or a
Mhm.
cream. I do actually use oral estradiol as well sometimes,
Yeah.
because we actually have better data with oral for cardiovascular disease prevention than we do for transdermal. So I don't use it in someone who's high risk for blood clots, but I do sometimes, I do like oral estradiol, but estrogen of some sort, one of those two types, and then pair it with progesterone, with bioidentical progesterone, which is usually going to be an oral capsule
Right.
most commonly, although those actually can be used vaginally as well, which is interesting. If you have a lot of symptoms from the oral capsule, you could take the oral capsule, the pharmaceutical type,
Right.
the gel
Right.
caps, and you
Right.
can actually use them vaginally. That's been studied. It's actually in
That's
guidelines.
interesting. I didn't know that.
Yeah, it can help a lot when women who have a lot of, either too much drowsiness or depression, or, like, any kind of, like, anxiety, any kind of, like,
Mhm.
brain symptoms from
Mhm.
progesterone. They're very sensitive. If you give it to them vaginally, then it can cut down on those symptoms, because you're bypassing the liver metabolism, which is
Right.
what's causing the metabolites that cause those symptoms. So
Sure.
it's a kind of a nice. I mean, obviously talk to your doctor first, but it can
Right.
be a really nice way to do that.
So I have two questions that came out of all that. So one, just for our listeners, could you explain the difference and why someone would prefer to take an oral estradiol versus a topical one, such as a patch? Why would somebody want to do that?
Well, I will tell you there's a lot of debate, and that most doctors in the space probably would say you should just take a transdermal. Like most people will say
Right.
transdermal, and transdermal is by far this, it is the safest. It does not increase blood clot risk. It is very safe. But there is better data for improving your lipids. For example, with oral, oral will improve your LDL, your HDL, your ApoB, even your LP little a, which is a very specific lipid.
Hmm.
Oral
Hmm.
will improve those lipids 2 to 3 times better than transdermal will in the studies that have been done. And we have several randomized controlled trials that we can actually reduce cardiovascular disease with early use of oral estradiol. We have 0 randomized control trials that we can reduce cardiovascular disease with transdermal
Right.
estradiol. And
Interesting.
part of that may just be that we haven't done the studies yet. Like I think that there's a big data gap for sure, but there may be something about that liver metabolism
Yes.
that's actually
Yes.
beneficial for preventing heart disease and certainly for the lipid piece. We think the liver, just going through the liver first
Right.
is probably why it improves lipids better.
That's very interesting, actually. Very, very interesting. So I guess the other question I have is, I think I had heard you mention this on one of your other social media posts about, do you check estradiol levels in patients that you're giving supplementation to? Why? Why not? Because I know there's a lot of doctors out there who are like, no, you just go by symptoms. It's all clinical.
Yeah.
But you had said something different that I thought was very provocative and interesting.
It is provocative. And yes, I do check levels. The reason being, we know that especially with like patches, for instance, patches and
Hmm.
gel, anything transdermal, the absorption is very different from one woman to the next. Like some women can be on the highest dose patch, and if
Right.
you check their estradiol levels in their blood, it can be quite low. Someone else can be on a high level patch and have high levels, and this has been shown and proven. And when we're looking at disease prevention, not
Hmm.
just symptom relief, but disease prevention, then it makes sense that there would be a therapeutic threshold, right? Like
Yep.
it just from like we know this in medicine that
Yep.
there's a threshold where we need enough of that medicine to reduce your blood pressure or to help your thyroid or whatever it is.
Right.
And so to me, the idea that we know that this is probably true, but and yet we don't acknowledge that checking your serum levels is appropriate or necessary, or even being researched, that to me seems silly. So I do check serum levels. I like the estradiol level to be between about 65 and 150 picograms per ml. Everyone's a little different, certainly, but that's a range that I think is bone protective, and cardiovascularly protective. Potentially, we don't know much about the brain and ranges, but at least from those two standpoints, that range makes sense for most patients.
So repeat that again, 50 to 60 to 150?
65 to 150 is the range.
65 to 150 picograms. Wow.
Yeah.
Yeah. No, I actually I agree with you. I think what everything that you said makes so much sense, and that, it's actually should really be looked at. It really should be
Yeah,
evaluated.
we need more
Um,
studies. I mean, we need
yeah.
I had to kind of cobble together, a bunch of studies that have been done and the pharmacokinetics data that we have that tells us, what serum level you can get from different formulations of estrogen. So I take that information with the different studies, cobble together kind of why I chose that range. And I have a Substack written on this if you want to review it.
Yeah.
But it certainly are not medical guidelines on this. I certainly could be wrong by a little bit. Like it could be maybe it's 55, maybe,
Right.
like
Right.
I'm not saying that I know all the things, but I do think that there is a level and that we should be checking, we should be doing more research to find out exactly what it is.
Right. So we're not just prescribing this hormone therapy just to get rid of your hot flashes and your brain fog. We're actually
Yeah.
trying to make a difference in terms of your longevity and your overall health, right? So
Yeah.
I think that's actually brilliant.
Yeah.
Really brilliant. So I really look forward to collaborating with you in a few things. I have a whole bunch of ideas. I can't wait to get you offline so we can talk about it. But
Oh, good.
last thoughts for our listeners?
I love women's health. I love hormones. I want to collaborate with you too. I think we have a lot to talk about in terms of, I think that the breast cancer space, the breast cancer and hormone space is certainly
Yep.
needs, there's a lot of research
A
that needs to be
lot there.
done.
Yep.
There's a lot we need to learn, and we need to do a lot better job at treating our breast cancer survivors. I think, you're
100%.
you're amazing, and you're probably not the I think you do this. Your approach is different than I think a lot of
Yeah.
um,
I
physicians, and I think, I need to do a better job. We all need to do a better job in that population. So I'm hoping that, with people like you and me and other doctors in the space, that we
yeah.
can just help women in general, but especially breast cancer survivors in a
Perfect.
better way.
So if you're not already following Dr. Amy Killen, please do. Her Instagram is at Dr. Amy B. Killen, which I have down below. And I will post in the notes her Substack information as well, because it's really great. I read yours and I don't read a lot of them, I have to
Oh,
say. So
thank you.
I appreciate you. So I hope everyone enjoyed this episode, and thank you so much for joining us. And we will see you next week.
Thank you so
Bye.
much.
Thank you.
Bye.